Magnesium sulfate has been identified to be an effective neuroprotector, and that is a very important aspect of using magnesium sulfate in better outcomes in preterm births. It is known to bring about stabilization of the cerebral circulation by stabilizing blood pressure and normalizing cerebral blood flow. This we have learned in preeclampsia. But in the context of preterm birth, it is known to exert a vasodilator effect in the fetal cerebral vessels, mitigating hypoxia and or ischemia induced brain damage. It also exerts an anti-inflammatory effect, resulting in decreased production of pro-inflammatory cytokines and free radicals, which ultimately decrease the cerebral cell death secondary to inflammation. Magnesium sulfate downregulates NMDA receptors for the neurotransmitter glutamate, thereby decreasing calcium entry into the cell and modulating a protective mitigation of excitatory action potential propagation, and thus prevents myometrial contractions, improves brain perfusion, and also possibly improves placental perfusion. And this has helped in not only prolongation of pregnancy but also awarding better brain protection if the baby is to be born. Now, if you look at the candidates which are to be used for magnesium sulfate for fetal neuroprotection, are the gestational age groups between 23 to 32 weeks of gestation, preterm labor with cervical change and high likelihood of delivery within 12 hours, preterm premature rupture of membranes, suspected cervical insufficiency with a high likelihood of delivery within 12 hours, and planned delivery for medical indications of obstetric complications that can safely be delayed for magnesium therapy. Does the patient meet any exclusions is the question that we must ask, and if they are there, then do not use. So what are these exclusions for using magnesium sulfate? Intrauterine fetal demise, maternal severe preeclampsia, because these patients are already put on prophylaxis of magnesium sulfate, fetuses with lethal anomalies, and maternal contraindications such as renal failure and myasthenia gravis. So, if such a contraindication exists, do not use magnesium sulfate. If there are no contraindications, load the patient with 6 grams of magnesium sulfate intravenously over a total of 20 to 30 minutes. Run a maintenance infusion of 1 to 2 grams per hour until delivery or 12 hours have elapsed. The patient, if at all, has been temporized for now. She has been tocolyzed and has received the magnesium sulfate and then returns back again at a later point in time, again as a preterm delivery imminent situation. In such a patient, one can consider again giving her a repeat dose of magnesium sulfate for more than 6 hours. So again we can load the magnesium sulfate and restart it with the same kind of 24-hour infusion. In my personal practice, I have found using such a magnesium sulfate in about 5 to 10% of patients requiring a repeat magnesium sulfate. Now, these usually were the ones who were conceived with ART and were presenting with very, very early preterm labor. So, we gave them one magnesium sulfate infusion which was to be repeated maybe once or twice, and we could take them to about 34 to 36 weeks of gestation. The average observation of prolongation of the gestational age that we effectively found, not in all patients of course, but has been even up to maximum of about 6 to 10 weeks. And I think this part, the positive aspect of using magnesium sulfate as a tocolytic and a neuroprotector, requires attention.